shall now go on to our next speaker, Dr. PARUL, who's a professor at the Department of Ophthalmology, PGI, and she's going to talk on a very important topic, glaucoma management in a patient with pseudoexfoliation. On to you, Dr. PARUL.
Good evening. Good evening, everybody. I work at the Government Medical College, Chandigarh, and I would be speaking upon glaucoma management in patients with the pseudoexfoliation. So we have this patient, a 67-year-old gentleman from Himachal Pradesh, who complained of decreased vision in the left eye since a year. He didn't have any relevant medical history. The family history was non-contributory, and there was no history of use of steroids or any past trauma. The best corrected visual acuity in the right eye was 20/20, and it was 5/60 in the left eye. There was an RAPD in the left eye. The pressures in the right eye of any medications were 19, and they were 29 in the left eye. The pressures increased after dilatation to 34 millimeters of the mercury in left eye. In the right eye, they were about 20 or 21. The optic nerve head showed about 0.4 vertical cup disc ratio in the right and a significant 0.9 cupping with bipolar notching in the left eye. The slit lamp examination revealed nuclear sclerosis, which was early in the right eye, and about 2 to 3 plus nuclear sclerosis in the left eye. On dilated lens surface, we could see the typical bull's eye pattern, and there was also some amount of scruffy deposit on the pupillary rough, although there was no peripapillary transillumination defects. The gonioscopy of both eyes showed open angles, and in the left eye, we could see a very prominent Sampolices line, as is very evident here. Pachymetry was towards the thicker side. The diurnal variation of intraocular pressures showed a significant amount of fluctuation in the left eye, with the highest pressure in early morning being about 35 and the minimum in the left eye being about 27. The perimetry in the right eye showed just a few defects, and the left eye showed significant defects, and there was a split fixation when the 10-2 test was done, which corroborated with the disc. The salient features of this case were that the patient was over 60 years old, was from a hilly terrain, had scruffy deposits at pupillary rough, and a classic target pattern on the anterior lens surface, a prominent Sampolices line, asymmetric cupping, significant diurnal variation, an increase in intraocular pressure on dilatation, and all this pointed towards the diagnosis of pseudoexfoliation glaucoma. The patient was started in both eyes on bimatoprost. A week after starting the treatment, the pressures were 14 in the right and 24 in the left. Another drug was added in the left eye, and that was timolol. A week after addition of timolol, the pressures were 18. The patient was given an option of getting a combined phaco with trabeculectomy done. The patient somehow did not want trabeculectomy either as a standalone procedure or as a combined procedure. So we went ahead and did a phaco surgery for this patient. Preoperatively, what is important to assess in a case of pseudoexfoliation is to look for zonular dialysis, phacodenesis, any asymmetric anterior chamber depth, and the corneal endothelium. And all these were missing. The corneal endothelial cent count was good. So we went ahead and did a phaco. It's a good idea to use a small incision size in these cases. So I used a 2.2 millimeter incision, did a large CCC, prolapsed the nuclear fragment in anterior chamber because I wanted to avoid zonular stress. In cases with pseudoexfoliation, chopping is a preferable technique. And as a safe option, I had taken a 3-piece IOL in case there was any complication on table. And acetazolamide should be given to these patients to prevent any post-operative IOP spike. Now, why should we bother learning about pseudoexfoliation management since it's an open angle sort of glaucoma? Well, isn't the management going to be pretty much similar to a primary open angle glaucoma? Now, angles may not always be open, and a lot of studies have shown that narrow angle pseudoexfoliation is quite common in Asians, which could probably be because of the zonular weakness, which causes anterior lens displacement, and hyperopia sort of adds to it. These patients tend to have an aggressive course. the rate of conversion of patients who have just high pressures to developing a full-fledged pseudoexfoliation glaucoma is quite high, to the tune of 40 to 50%. And the surgical complication rate is also quite more in patients with pseudoexfoliation. Additionally, when complications occur, these patients are a little bit more resistant to steroids as compared to primary open-angle glaucoma patients. So some practical pearls when it comes to medical management of cases with pseudoexfoliation glaucoma. We must remember the 24-hour IOP characteristics, and there are high IOP fluctuations in these cases. So one must aim to dampen the IOP fluctuation to 3 millimeters or less. Sometimes you may need to do a diurnal variation of IOP even on medications, and if you find that the IOP fluctuations are more than 3, then you need to address and revise your treatment. Therapy with multiple medications is needed, and sometimes adjunctive SLT needs to be done for these cases. The threshold for any form of surgical intervention should be relatively earlier in these patients. And medical therapy for patients who have secondary angle closure due to pseudoexfoliation is different from cases with primary angle closure, because here we don't want to give myotics. They will make it worse. Since the pathology is because of zonular atropine is something that needs for these cases. When we talk about intraoperative issues, if we talk about cataract surgery for these patients have poorly dilated pupils. So we either need to use, we need to lyse synechiae with blunt spatula, or do stretch pupilloplasty, or use highly viscous OVDs. For zonular fragility, you need to keep a CTR ready in case there is any problem on table. And what else we can do? That surgery needs to be done in early stages of the disease to avoid harder nuclei. You need to avoid excessive fluctuations in the anterior chamber pressure through the use of small incision and adequate viscoelastics. Tap the center of nuclei from time to time during hydrodissection to decompress the fluid and fluid pressure on the posterior capsule. And if you have a cannula which has 2 side ports from which you can do a gonial wash, then that is something that can be done at the end of a cataract surgery. So thank you very much for your kind attention.
That was a wonderful talk. You know, I had tried to think of all the questions to ask you, but you really covered it all.
Yeah.
The association of an angle closure disease and pseudoexfoliation you've covered, and also the unique issues which have to be addressed when you're doing a pseudoexfoliative case. So I'm going to try to ask any of the experts panel, Dr. Sunita Dubey, maybe, would you think that GAT is a better option in these eyes with pseudoexfoliation, or at what stage?
GAT. Okay. Yeah. Actually, pseudoexfoliation, as she has mentioned, you need to, because these patients are very fast progressors.
Yes.
And the chances of progression is pretty fast, and you over a period of time, the angle also becomes narrow. As the zonular weakness increases, there is progressive shallowing of the chamber and narrowing of the angle. So in the later stages, you may not see the angle structure so well. So I don't think that in the later stages, when the cataract,
no, not later stages, early stages of pseudoexfoliative glaucoma, would anybody consider doing a GAT?
Yeah, actually, I have the experience of trabectome. Trabectome works very well when there is pigment deposition or pseudoexfoliative material in the trabecular meshwork, which causes damage to the trabecular meshwork. So I think those procedures can be used initially when the glaucoma is not so advanced and there is progressive damage to the trabecular meshwork because of the deposition of the pseudoexfoliative material. And still, when the collector channels are open, the disease has not advanced up to the collector channels.
Yes.
In the initial early stages of moderate glaucomas, they can be considered. But when the glaucoma has progressed to the extent that it has extended up to the collector channels and the lens may be subluxated, there can be zonular weakness, then I think maybe with all precautions what Dr. Parul has mentioned, I think that should be kept in mind, and a combined surgery like phaco tract can be done, because these cases can progress very fast.
Dr. Sunita, would you have, I'm sorry, Dr. Shushmita, do you have anything to add here?
So, I mean, if I was doing just a cataract surgery and not contemplating a trabeculectomy, I might think of adding a GAT, which may make sense. But if the patient has a glaucoma which would require a glaucoma surgery, I would not keep GAT as my armamentarium. I would do a trab or a phacotrab. So depending on whether glaucoma surgery is required, that would. But yes, it would add to a phaco. So definitely in that case, I would consider a angle surgery along with.
Dr. Vijaya, can you tell us what would be the guideline in following up the fellow eyes if they do not have glaucoma?
Actually, pseudoexfoliation per se is to start with, it starts as unilateral. So with the time, only the other eye will develop. It's not uncommon. You see one eye pseudoexfoliation, other eye normal. But people say that if you do the conjunctival biopsy, you still will see the evidence of pseudoexfoliation. So you have to follow them up because you can't control it. At present point of time, we don't have any drugs that can address the deposits of the pseudoexfoliation. We are hopeful with the time. I'm sure that so much work is happening in the basic science. We may have some kind of a therapy that can reduce the deposit. Coming to the management of glaucoma, they are very aggressive glaucomas, unlike open angles and angle closures. They progress very fast. Blindness rates are much higher. I think whatever you do, it has to be a procedure that will control the pressure very well. I think we cannot take pseudoexfoliation lightly and try to play with it. As like Sushmita said, there is no cataract. I mean, there is no glaucoma. Just doing the cataract will take away a lot of material. Simple phacoemulsification itself will drain a lot of material because you use so much of vacuum. So it takes time for the material to get deposited again. So that even just doing a cataract without doing any further is a good option.
Thank you very much. We shall now go
Ma'am,
on.
I have a question from Sushmita, ma'am.
Yes.
The moment I explained the risk of a possible wipeout since the patient had split fixation, so he was a little reluctant to get any form of glaucoma intervention done. Ma'am, I had kept SLT as a stopgap in my mind that if the pressures start to rise after cataract surgery, I would consider that. Do you think that would be a valid option and would work well for this patient?
I'm not sure because if there is glaucoma, which requires control, I would try to counsel the patient for a trabeculectomy because they really, as Dr. Vijaya said, they progress so fast and we wouldn't have the time to experiment with whether or not the SLT would work with the pigmentation there. So I'm not sure I would offer that. I'd offer a surgery, a definitive surgery, if it's uncontrolled.
PARUL, just a small suggestion. If you tell patients the wipeout, you make it very clear to them. If you take a chance, there is a possibility you will maintain the vision. Yes,
Right.
there is a small risk of wipeout. If you don't take a chance, the chance of you become blind with the time, maybe in the next 5 years in pseudoexfoliation glaucomas, is 100%. So that will tilt the choice towards the surgery. I think, I'm sure
Surely, ma'am, will do that. Yes, ma'am.
Thank you, Parul, and thanks expert panel for